one. Yes, so we're live now. We can begin.
Good afternoon, friends, Foxy members. I'm Dr. Pragnesh Shah, Gynecologic laparoscopic surgeon, giving training since last more than 30 years in Ahmedabad. I'm going to talk about structural endoscopy, the need for patient safety and legal safety. I just want to have a disclaimer. This presentation is not for restricting anybody and validating anybody and restricting anybody for doing laparoscopic surgery and hysteroscopy surgery. So please don't take it personally. I'm just putting my thoughts forward for understanding the need for legal and our professional safety. I request, if you feel that it's sensible, just try to implement in your professional growth and career. I request all of you, just click the link. I send the feedback form, fill up the form because this will help to improve in future and strategic planning of structuring of this endoscopic training and practice and mentorship. This is really important for every professional bodies for increasing their commitment to provide a missing link between research and implementation of this educational tool in a structured educational programs in future. We should create and multiply opportunities for improving personal and professional development of knowledge and skill through mentorship. Developing structured assessment and validation is the need of our instructor program. Now, why gynecologists should learn endoscopy surgery? There's a paradigm shift in our gynecological surgical practice. There are many classical surgical surgeries are replaced by endoscopic surgeries. Now, if you don't offer this option, then you will lose your patient. So, classical adaxial, ectopic, mammectomy, hysterectomy, endometriosis, prolapse surgery, complex, difficult surgeries, cancer surgeries, septum, polyp, submucous fibroid, Ashenman, because the stay is only 1 or 2 days and she can resume to her job within 2 days after surgery. And this is the reason why this is going to be a absolutely necessary for all of us to learn correctly. Now look at a scenario: flying in aeroplane and the in cockpit, and the pilot starts announcing there's some noise, there's some problem, it's just moving, seatbelt fast kar do. We are trying to find out the problem, we are trying to solve the issue. uh, I've taken training in aeroplane simulator for 3 days. I've attended 3 4 short courses, long courses, 1 month, 7 days, 3 weeks. I'm having experience as a pilot in few flights. I've seen many videos in YouTube. Don't worry, nothing to worry, God will take care of all of us. Very same way, imagine a situation: a so-called laparoscopic surgeon who has done few lap TL operation during their residency starts saying with a complication following a surgery, see, I have attended 3 4 endoscopic conference, taken a training for only laparoscopic hysterectomy with harmonic and vessel sealing. I have attended one 3 day course and one 2 day course. I've seen 10 videos. Will you allow your wife, daughter, or mother for a laparoscopy surgery with this kind of so-called endoscopic surgeons? If your answer is no, why would you put someone else, wife, daughter, mother, under such at risk without structured training? And look at the endpoint. Now there are plenty of online advertisement. In US, this legal experts are ready to do medical suit against doctors. They're advertising like this. Come to us, we'll give $1 billion, putting a shoe against doctor for this, and this. And imagine if you aren't taken a structured training and practice, what can happen? So we need a legal security. We need a safety from the patient. And that is where lies the importance of need for structured endoscopy. Let's begin with understanding where we are lacking as of now. There are many people who are doing laparoscopy surgery, but to whom it should be done or not done, when it should be done, how it should be done, why it should be done, and by whom it should be done. Understand this. You might have seen in some patients doing laparoscopic tubal reversal, even the age is more than 45 and AMH is low. Do you think it's going to give a fertility promotion? I've seen in many workshops, even senior people are doing laparoscopy surgery for fibroid endometriosis. Age is less than 30. AMH is normal. Not doing tubal testing. Don't you think this is ridiculous? They don't do even hysteroscopy. Don't you think this is ridiculous? Now, I'll just give one example. People learn, it's fine to learn retroperitoneal dissection, but you're not working in oncology department. When you do per rectal examination, your finger cannot identify free space between growth and pelvic wall. Means you cannot differentiate between 2B and 3B. You cannot differentiate between non-operable and operable case. You are demonstrating laparoscopic version operation. What is hell opening in a practice? Missing preoperative counseling for tuberculosis. An assessment, prediction, assumption, you ending with injury to the intestine, and then colostomy for 6 months, ileostomy for 6 months. This is where we need to understand. See, when it should be done. Again, a patient भाग जाएगा. We do a fertility promoting surgery after the ovulation. 14-day of cycle. Even the age is less than 30. Is it something that we should be doing or not doing? We just do transvaginal sonography. A lot of times we miss doing PSPV examination in our OPD. And when we, under anesthesia, start doing laparoscopy, hysteroscopy, we find bleeding, we find infection, and you continue doing procedure. What is happening? What about redo counseling and detailed counseling? ये हमारे वहां आ जाओ 100% रिजल्ट आते. What is 100%? There's nothing 100% medical practice. So you have to explain about what is called as far as the procedure result and complication is concerned, at least when you're doing redo surgery. And this is where you need a structured checklist. SOP is called Standard Operating Protocols. How you should be doing it. That is also should be streamlined, structured as far as training and practice is concerned. You have to convey alternative treatment. You have to convey about outcome. Don't have obsession of saying 100% result. Check your all instrument specific required for specific procedure. In the middle of surgery, you find that morcellary is not working, bipolar is not working. To save the money, people do laparoscopy surgery under spinal anesthesia. See, when you do pneumo, head low, there will be a pressure on diaphragm. And if you're not done intubation, can you imagine what can happen? And how you defend in court of law if patient dies and done a surgery laparoscopy under spinal anesthesia? The cautery paddle has not been placed well and complication. How will you explain to your patient? Lot of times we do laparoscopy and we don't do a reporting checklist. We don't see behind the ovary, which is the commonest place for endometriosis. So you've done laparoscopy and you overlooked endometriosis. See, this is where structured endoscopy is relevant today as far as the patient safety and legal safety is concerned. To begin with, structured endoscopy, three important arms: training, practice, and future validation, validating your skills. Let's start with the training. Look at the scenario. There's a mushrooming of training centers. 93 Foxy training centers for basic and advanced course. 19 Foxy ICOG 6 months course. 6 IAG fellowship 3 months course. Surgeons giving lab training to gynecologists and giving diploma certificate. My gosh, 7 days diploma. Gynecologists giving hysterectomic training for 1 month and taking lakhs of rupees with vessel sealing. And consider this is a laparoscopic training, advanced training, diplomas, cadaver, simulator, peak, online. See, mushrooming. Half day master class on endometriosis robotics. So you learn robotics in 3 hours and you get certificate. And look at the situation in medical colleges. I just don't want to hurt my head of the departments, but 90% of the medical colleges, they start doing laparoscopy surgery, few people and two people doing it without proper training and with complication. And now HOD is not allowing anybody to do laparoscopy surgery. So in spite of instruments available in all medical colleges, more than 90% of the medical colleges are not offering laparoscopy surgery in residency program. Can you imagine the pathetic situation in our country? And this is where Ghana is confused. Where to take the training, how to take a training, from to where to take training. So I just want to convey that please send your feedback form. So this will help. Send your queries and questions in chat box so we can discuss at the end of this presentation. Now let's coming to actual topic. What is structural endoscopy training and practice? It's something like level 1, level 2, level 3. In residency, 1 year you get episiotomy, and in third year you get a hysterectomy. So there is something like same thing in hysteroscopy and laparoscopy. It's a learning curve. And then you have to learn, you have to do it independently. It's not something that one do, assist, and start doing it. So there is a checklist. Please understand, there is a checklist, a procedure specific consent, pre-op patients checklist, instrument checklist, post-op checklist, reporting of surgical data in specific software to do a data analysis of complication and detection of near miss complication involving participating multicentric studies. How many laparoscopic surgery centers have participated in multicentric studies in our country and publication in index and journal? So this is where we need to do introspection and need for structural educational mentorship, validation for every laparoscopic level. There is a benchmark specific exercise, maybe on a simulator, maybe on a pelvic trainer, maybe on a hysterotomy trainer, then on a peak, then on a online simulator, then on a cadaver, and then actually on a patient. And of course, you can have an enhancement with this kind of CMS and conferences. But then this guideline needs to be identified and understood well. So I'm not going in detail about, there's a Delphi's kind of a project for evaluating residency endoscopic training programs. So there are various research has been carried out in Australia, in Germany, in France, US, to understand different training programs, including online video training also. But then it has to be understood, it has to be reviewed by different bodies, academic council, and institutes. I'm not saying that you follow this or X or Y protocol or methodology, but there has to be a comprehensive project which is applicable to different institutions, different professional bodies, maybe Foxy ICOG or IAGE, which is applicable in a different situations. But it has to be defined in a various benchmark exercise for validating level 1, 2, and 3. Now, in a comprehensive way, it includes two important components. One is theoretical part, and another is practical part. In theoretical part, you may be learning, but a practical part is skill of is camera navigation, appreciating in a simulator or bimanual way something called hand-eye coordination skill, counterintuitive movements of instrument while performing surgery. Of course, validation is very monitoring this quality control and validation is very important. So in theory, of course, theory of anatomy, indications and pathology, surgical techniques, suturing, hemostasis, dissection techniques, anesthesia, basic part, I'm not saying in detail, with muscle relaxant, painkillers use, multiparameter monitoring, ETCO2, importance of ETCO2, it's very important. The moment she had embolism, ETCO2 from 30 it will become 10. It's the earliest clue you can identify of embolism, maybe in a hysteroscopy or laparoscopy surgery. So you have to invest in multi-para monitoring and understanding the findings. Important point is about the instruments, indications, and technique relevant to relevant specific procedure for optimum performance is very important. We can always, like in US, go for uniform software for data entry and operating notes. Then only you can do a multi-scientific study, meta analysis of your data, operating photos and videos, and auditing your own cases in your institute. In practical part, there can be many things like this is what we are seeing: courses, lectures, videos, steps. But what is important is developing customized way from basic to more and more complex tasks. Surgery exercises are designed to develop different types of skill required. To begin with, on a simulator, pelvic tenor, tenor, and then actually on a mirchi, and then actually on a peak, and then actually on a computer simulator, and then on a patient, and put it on a chart and see that how a preceptor, a mentor validates it. I'll show you how it should be validated. So this is very important. Designing this is very important. You need to understand while you are designing, there is a specific requirement about understanding energy sources with different plethora of energy sources where it should be used, a good preoperative assessment selection, understanding your own limitations over checklists, intraoperative considerations, a probable bowel or a ureteric or a bladder injury, anticipating pre-op and intraoperative identification. This should be in a checklist, I'm saying, in a specific procedures. Anticipating and avoiding is very important for complication. See, complications identified and addressed is not an issue, but if it remains unaddressed, it creates a complication, legal implications. Understand different hemostasis and, and medical legal implications. I think I can go on detailing everything, but then there's a limitation of time. But understand three, four important points. Instrument maneuvering, camera navigation. This is something which is needs to be monitored by a mentor, your teacher, your preceptor, whether you are doing it correctly or not. And then tell your student that you practice on pelvic tenor. You can't practice on a patient. Okay. Now, if you're done up to tubal ligation, salpingectomy for ectopic, it's level 1. Cystectomy, level 1. Diagnostic, level 1. But then fibroid and this level 2, and then there's level 3, and then there is a level 4. So understand, is structuring these all different surgeries. Of course, a suturing, adhesion techniques, and different things needs to be learned appropriately. Now, this is again at least basic thing. Just you can put this chart in your hospital or OT. This is a patient's checklist, standard operating protocols. As far as before surgery, okay, patient's positioning. Look at instrument check. Look at check before putting an incision. See, these are the something that you can put it before giving anesthesia. So you may not have to struggle actually while you're given anesthesia, but now cautery is not working, now suction machine is not working, now CO2 is empty. So these are the few things that you always face. But unless you put it on black and white checklist, you can put this print in your operation theater. So you can have a cross check, somebody to cross check, maybe your paramedical staff, so that you may not end up with unwanted issues. Same thing, this patient operation preoperative checklist means it's very difficult to make you realize that how each and every point is important. So if you not remove the nail polish, your pulse oximetry will not show oxygen level. See, latest sonography report. Then what you need to do is whether you will need, do you have a skill that you are going to perform a surgery or not, adequate exposure or not, skill or not. If suppose there is a problem, what you will do, that you should discuss with your patient, whether you remove ovary or not remove ovary, history of ovarian cancer in family or not, should be discussed. So put it in a checklist so you don't miss this. PP kit, now COVID, RT-PCR, so all checklist. You may need GI surgeon, you may need urologist. In middle of surgery you can't call boss, आ जाओ यार intestine का कुछ लोचा लगता है. No, you should have told your GI surgeon, this is I'm anticipating, I may need to call you. Record your video, show it live to convey confidence. Do your auditing, learn. I tell all my students who are coming for 6 months Foxy ICOG course, fill up the performa of every surgery after surgery is over. This is short question, long question, learning points, operative not. In the learning points, identify which were the shortcomings in terms of camera navigation, instrument bringing to the target tissue, not teamwork, showing a vaginal manipulator properly during TLH, or assisting from opposite side, not doing suction appropriately and just abdomen collapse. This all should be written in your performa, and you see that these mistakes are not repeated in subsequent surgery, and this is what they have to write in their daily performa, and this daily performa is included in their logbook. And this is what the need of everyday assessment. Why IIT management institutes are great and merits, because they have daily assessment, the daily assignments. It's not something that लास्ट 10 days एक पढ़ लिया एंड आ गया, ऐसा नहीं होता है. यू हैव टू हैव एवरी डे असाइनमेंट टू डू, fill up in a assignment performa every surgery in case you see. Don't practice on a patient, practice on this different hysteroscopy models, laparoscopy models. These are cheap, easily available. It comes around 10,000 rupees. You can buy of your own, even for continuing your practice. But this is what needed for practicing on benchmark exercise for validation. Understand this. This is important. And now coming to actually curriculum. Curriculum. Please understand. Once somebody comes for, means this is what Delphi's model, but I'm not just saying that it's true. Just apply it according to your customization in your institute. What they should be doing daily for 5 days in a first week, in a second week, in a third week, in a fourth week, in a fifth week, in sixth week, or very same way, first month, second month, third month, fourth month, fifth month, and sixth month. So there has to be a design, structured, written, clear-cut lines that what they will be doing daily when they are here from morning 11 a.m. to evening 5 p.m. नहीं सर मैं आज जाऊं, मैं आज भाग जाऊं, नहीं ऐसा नहीं चलता है. You have to understand, if you want to reach at the end of 6 months at that particular level, then you have to have all this needs to be filled up every day, entered in logbook. This should be sent to Foxy and Foxy ICOG daily by email. Computer compiles every record and assess everything. Same way for little advanced course. Okay, what should be in first week, second week, third week, or first month, second month, and third month, or first day, second and third day. Same way for more and more advanced course. Look at this. Now, why I'm saying this, you may not get opportunity of seeing every surgery, complicated, difficult, rare surgeries, but you can always get the advantage of seeing a video of a large fibroid and then learn. Do a session of 2 hours with your teacher, your preceptor, which are the way we should be doing it during surgery, anticipating before surgery, intraoperative assessment and surgery, and of course, assessment. So this is what, while you are giving and appearing for rare surgeries, okay, your logbook filling, you should almost attend everything in 6 months. And then your comes mock test, exam theory, assessment on a pelvic trainer, at least you can do it. And your preceptor tells you that yes, you have done it well. How? This is again very important. Look at this. Score is from 1 to 10. Okay. First, to begin with, histo or laparotrainer, pelvic trainer. Then on computer simulator. Maybe on a software online. Maybe on a assisting in surgery. Maybe on a cadaver. Maybe on a pig. Okay. But then this should be given here. How your student has done camera navigation, target navigation, instrument navigation, coordination with primary surgeon and assistant, grasping suture needle, cutting round circle on a paper, clip application on tubal structure, pig transfer. See, all this very specific, very specific. You can see here for skill assessment for basic course. Very same way for intermediate course. See, this is the level 2. Again, camera navigation, target navigation, instrument navigation with coordination with assistant. First with pallet trainer, simulator, with computerized, with big cadaver or online. You can practice here till your mentor says that yes, your this benchmark exercise up to the mark, and then you validate. Don't validate because he's or she's known to you. Unless it's done a proper job, you should not validate it. Or if you feel that there may be a personalization, leave it to the software and computer to validate it. It's absolutely neutral. They will come that you have to do it in this way. Imagine a situation, if this system doesn't come in a practice, if one of the minister's wife dies because of non-validation and accreditation, then in Lok Sabha and Rajya Sabha, there will be passing of a mandate. Unless they are validated, they cannot do laparoscopy surgery. Then what you will do? And then they will request a recommendation from NCI. If they don't do, universities don't do, medical colleges don't do, Foxy ICOG, IAG, where these people are. You know, please understand. This is very important. That how AAGL is doing. They are seeing 25 surgeries or recorded videos of first surgeries of person who has done 2 years fellowship. This is what you can do it. This is already they are doing it. And we can also do it to check the competency. And this is what the need of actually validation and quality assurance mechanism is. See, these are the computers. These are not Pragnesh is validating. You don't need somebody to validate this. You can have a curriculum. This is recording. You can have your performance and records validated for individual specific skills. There's a management system. And then you grant the privileges. You see, it's not something that I'm restricting somebody to do this. Understand this. They are not far that if you don't do this, there'll be a day then somebody has to implement this. And there is always a place for maintenance of skill, and every year renewal of your license. This is what in US they are doing, that every consultant has to renew their surgical skill and license for practicing. And this is what again a need with the background of assessment with all non-dominant hand access. See, there are so many things that you can validate in a different ways. If you ask me, नहीं पेशेंट में कैसे करा सकते, अरे ट्यूबल लाइगेशन पेशेंट तो सबको आते हैं. Why you are not asking your student to do it, a tubal ligation and salpingectomy in a patient and validate whether he's doing and using bipolar properly or not? At least this you can do it to validate his level 1 performance and skill. This is something which you should be doing. See, what is important is what is the operative time from incision to wound closure? What is blood loss? Which are the complications? They have done it. How they've done hemostasis and checking of this conversion to laparotomy, length of hospital steps, and again put every data in a computer. Please understand this. This is very important. And see, let me tell you what American Association of Gynecologic Laparoscopists has done for patients and legal safety and last many years. What they've done, design level 1, level 2, level 3 basic courses and validation. Design structure training program. Design, this is important, faculty development program, preceptor development program. Means we had enough center heads. I don't understand why we should not organize preceptor development program who validates their candidates in their training centers. Need for accreditation counseling of Foxy and Foxy ICU and IG. Need for training of donors. Nobody feels that I means we even examiners have to appear in exam to take somebody's exam. That is what the need of AAGL are doing. It's not something new I'm saying. There's something called electronic medical record, uniform software and data and math analysis. Look at the situation, our Foxy members' situation of research work. How much we are publishing in index journal? How much actually you are putting? See, we can't afford a software where we can put our data uniformly. So I think these are the few couple of things I feel that we can definitely do it. It's not applicable. ये प्रज्ञेश तो बड़ी बड़ी बात ही करता है. It's not बड़ी बड़ी बात. Please understand. What is important is if it is likely to give your legal safety and patient safety, then please understand the importance and need of this of pre and post feedback. Don't forget to give feedback to me. Send it to my email or maybe in a Foxy. I don't mind. But send a feedback. So let people understand what Foxy member wants. Assessment, auditing of your cases is important. Complications is important. Because if you're not going to do this, you're not going to improve. So it's not for criticizing, but reviewing your meetings for prevention of future strategies and near miss complication is very important. So there has to be something like auditing, quality control. Look at chartered accountants. They have a quality control they have started now. It's not that simply somebody sponsored program, you attended, certificate, and credits are validated. No, that is not validation. That is not validation. Please understand. So, just I want to summarize my presentation. Introspection and future safety. Surgical education is still an evolving field of research and novel methods of surgical education which change frequently. Surgical curricula and model surgeons. But we professional. I was a Foxy endoscopy committee chairperson. That is why I'm inspired to say that our commitment to provide missing link between what is necessary in structural endoscopy and what is existing in educational tools in structural endoscopy needs to be reformed. This is what called mentorship create opportunities for improving our personal and professional development and mentorship through skills, developing structured training, practice, assessment, future progress in a structured way is going to help us in a long way. So, dear friends, at the end of this my presentation, I request all of you to send a feedback. And if you feel that, try to implement this. And we should be, a pioneer in doing something, even though somebody has not done in world, pioneer in providing a evidence-based, supportive, innovative educational structure program for our Foxy members. Thank you so much. I will love to answer your questions. I think I completed my presentation in 36 minutes. I've got another 10 to 20 minutes and left more time for all of you to answer your questions because बोलना तो ठीक है, but what is actually your problem and understanding is more important according to me, is relevant. So I love to answer your questions and queries. So put it in a you know sidebar, your comments, your questions regarding my presentation of structural endoscopy for patients and legal safety. Thank you. Hello, I'm audible or I'm lost?
Sir, you're audible. You'll find the questions in the response sheet.
So how to find my response sheet? Guide me, beta.
Sir, uh, sir, can you open the? Yes, perfect. This one.
Okay, now I'll just start saying this. Dr. Nina is from Varanasi saying that recent guidelines on this. No guidelines. This is what pinching me. I was endoscopy committee chairperson in 2010. This is 2020. I've taken a feedback in 2010. No guidelines. Okay. Number two question. Saransh Bhatia from Delhi. Consideration of elective surgery during SARS-CoV. Do we follow separate protocols? Of course, beta. And I'm very happy to say that IAG has given clear-cut guidelines. Foxy has given clear-cut guidelines in giving a separate protocol during COVID-19. This is the best way Foxy and IAG and Foxy ISUG can do of mentorship. This is called mentorship. You should be giving, we should be giving clear-cut guidelines to our Foxy members the way we are given during COVID time. Thanks, Foxy and Foxy ISUG and IG. Sita Garg from Surat. Consideration of urgent surgery, of course. Mithun, will practical laparoscopic training in certificated training is included